Welcome everyone to the winter term, and I hope everyone had a good break, and we're now a bit recharged for the winter term. So we're very fortunate to have Dr. Lucio Bain with us today. But before we get started, I'd like to offer a land acknowledgement. And as this is a hybrid event and some participants are on different territories, we'd ask that you take the time and space to give thanks and gratitude and respect for the land that you're currently living and working on. And as we're here on the York University campus in Toronto, we're situated on the traditional territorial area known as Tkaronto, and we acknowledge its current treaty holders, the Mississaugas of the Credit First Nation, as well as the traditional territory of many Indigenous nations, including the Anishinaabe Nation, the Haudenosaunee Confederacy, the Huron-Wendat, and the Métis. This territory is also subject to the Dish with One Spoon Wampum Belt Covenant, an agreement to peaceably share and care for the Great Lakes region. So let me begin with giving some background on Dr. Bain. So Dr. Bain is a global public health physician, implementation research scientist, and empirical bioethicist with over 15 years of global health experience. Currently, he's the head of international programs at the African Population and Health Research Center in Nairobi, Kenya. He's previously served as Senior Program Officer with the International Development Research Center, the IDRC, in Ottawa, a Senior Research Fellow in Global Health with the University of Lincoln in the UK, and has worked as a consultant for various international organizations, including the UN Population Fund, the World Health Organization, the Bill and Melinda Gates Foundation, and Population Services International. Lucio is an associate professor of global health and bioethics with the EUCLID University, Euclid University, a research fellow at the Davila Institute here in Toronto, a senior research associate with the Department of Psychology at the University of Johannesburg in South Africa, and an inaugural fellow on climate change and health of the Geneva Learning Foundation. Lucio is a current member of the WHO's Department of Sexual and Reproductive Health and Research, Sexual Health and Wellbeing Advisory Group, and a technical working group member to the Africa CDC, supporting the development of its annual Public Health Intelligence Report. Lucio has reviewed proposals for the NIH, research in primary healthcare in the UK, and the European Commission. He holds a PhD in Transdisciplinary Global Health Solutions from the Vrije University in Amsterdam, an executive MBA in Strategic Human Resources Management from UNIR, a Master's of Science in Bioethics from the Catholique Université Louvain, a Master's of Public Health from Hebrew University, an MD from the University of Yaoundé in Cameroon, and executive training in global health diplomacy from the U of T. He's published over 100 papers in peer-reviewed journals on many topics, including sexual reproductive health and rights, ethics, decolonization of global health, HIV medicine, and health policy. So with that, we'd like to welcome you, Lucio, to offer your talk on It's Time to Save the Decolonization of Global Health Movement, the Urgent Need of a Paradigm Shift. So over to you, Lucio, and thank you so much for being here.
Well, thank you, Mary. Thanks for the Institute for inviting me, and I would most importantly, especially like to thank James Obrinsky for making it possible for me to get the connection with the Institute. So it's actually a privilege for me to share thoughts on decolonization of global health. And I think, thanks for the generous introduction, and I'm aware of time, so I'm going to jump straight into the presentation. I would just like you to confirm if you can see my screen properly and if my slides move properly.
Yes, and yes.
Okay. Thanks so much. And what I'll have to say is it's not that it's not going to be a lecture. It's actually going to be more of questions than answers. There is general consensus that global health should be decolonized. The process of decolonization of global health is going on. But there are core questions whether is the decolonization of global health movement actually a meaningful movement? And it's from this background that I actually coined the title of this talk, whether it is actually time to save the decolonization of global health movement, because it's really important to actually shift the paradigm. And as I discuss, we're going to get exactly the reasons for this. As I mentioned, and you mentioned earlier, yeah, I actually serve with the African Population and Health Research Center, which is a premier research policy institution aimed at generating evidence, strengthening the research and related capacity ecosystem in Africa. It's headquartered in Kenya, here in Nairobi, with an office in Senegal. We have presence in over 35 countries in the continent with over 160 active projects, with three main divisions, the first being the research division, the second being the research and related capacities strengthening unit. I insist on capacity strengthening, not capacity building. And the third being the policy engagement and communications unit. As an institution, we are very intentional on the fact when it comes to knowledge translation. And that's why we invested in actually hiring over 40 staff to work mainly for policy engagement and communications. We are keen and very keen on co-creation, gathering diverse experiences, and because we are very core and we are actually one of the leading organizations when it comes to the decolonization of global health in the continent. And we are leading a core work to actually come up with a blueprint piece of work on the decolonization of global health in Africa. Maybe I just insist that the African Population and Health Research Center has been existing for the past 22 to 23 years. So we have quite some experience in doing global health research. And at the Institute, I currently serve as head of international programs in charge of partnerships and coming up with an internationalization strategy for the organization. I'm going to start with a couple of quotes, and I know that I'm very convinced that by the end of this presentation, you actually understand or appreciate the importance of these quotes. The first is from Sarah Bimbola, who says, decolonizing global health is not about replacing one hegemonic system with another, but dismantling systems that perpetuate inequities and building ones that promote justice. It's important to note the word inequities, not inequalities. The second is from Pai, who says global health remains dominated by the global north. Until we tackle power imbalances, global health will continue to perpetuate the very inequities it seeks to address. The note on inequities. Audre Lorde says the master's tools will never dismantle the master's house. Paul Farmer, the lead, global lead when it comes to equity, says the idea that some lives matter less is the root of all that is wrong with the world. And Patricia Garcia says, come in and ask us what we think is important and create capacity. What is global health? This is a very important question, and over the years, there is actually no consensus when it comes to the definition of global health. But one of the most used or adopted definitions of global health was proposed by Copeland and colleagues in 2009. And they say global health is an area of study, research, and practice that places a priority on improving health and achieving equity in health for all people worldwide. Global health emphasizes transnational health issues, determinants, and solutions, involves many disciplines within and beyond the health sciences, and promotes interdisciplinary collaboration. Maybe it's important to note what is highlighted in red. And a systematic review that actually focused on the definition of global health, led by Melissa and colleagues, actually highlighted four main aspects of global health. The first is global health deserves a multiplex approach. Global health is ethically oriented initiative that is guided by justice principles. Global health is a mode of governance, involves political decision-making. And global health is a vague and yet versatile concept. It's important to know the fact that global health is vague and yet versatile with multiple meanings. However, irrespective of the lack of consensus on the definition of global health, there are some core aspects that have actually gathered some level of consensus. Global health is grounded on equity, solidarity, justice, humanity, and ethics. But if you look at the lessons that we gathered from the period of HIV, Ebola, COVID-19, and Mpox, looking at the various dimensions when it comes to the timely access of drugs, the timely access of vaccines, equitable access of vaccines, and how clinical trials were done, where clinical trials were done, who the persons that actually benefited from an economic point of view from these clinical trials. I'm thinking of the vaccine sales and the drugs. We question whether global health, in fact, whether equity was respected. We say no for COVID-19, for instance. Solidarity is no, justice is no, humanity is no, ethics. There are lots of ethical issues when it comes to global health. Therefore, there is actually a need to decolonize global health. It is blatant that we see of colonial legacies and historical injustice. There is an epistemic capture of global health, and we're going to see this in course of the discussion. And Daniel Krugman, one of the leads in this domain, has actually described it as the elite capture of knowledge or within global health. And the notion of epistemicide is actually clear. What is epistemicide? The killing, silencing, annihilation, or devaluing of a knowledge system. And within the global health system, we understand that there is a lot of epistemic dominance where knowledge is considered knowledge if it comes from the global north. There are descriptions of epistemic violence, arrogance, and injustice. It's clear that the houses of power within global health are found in the global north. We think of leadership, funding, and epistemic dominance, as I mentioned. Have the partnerships that we have been found that actually go on within the global health architecture. We're thinking of global health research, international development, and funding agendas and implementation agendas. Have these been equitable? No. And it's because of these inequitable partnerships that the decolonization it is mainly because of the inequitable partnerships that the decolonization of global health actually was born. If you look at from the ethics side of things, there are lots of questions. Not only do we see have a lot of prevalent helicopter research, but we have a lot of helicopter ethics approvals. You have a study that is conceptualized maybe in Ottawa or in London, and is implemented maybe in Benin, and no ethics approval is obtained in Benin. These are things that are still glaring. These are continuing, and it's really time for us to decolonize global health. When we look at privilege, power, and priorities, it's important to answer the question, who is who in global health? The data is clear. 2/3 of global health agencies are headquartered in just 3 countries, Switzerland, the UK, and the US. More than 80% of CEOs and board chairs of global organizations are nationals of high-income countries. A typical CEO of a global health agency is 3 times more likely to be male, 4 times more likely to be from a high-income country, and 13 times more likely to have been educated in a high-income country. So why should we decolonize global health? This is a core question. And if you look at the reflection from Richardson on the coloniality of global public health, he says, the continued inordinate demise from communicable pathogens in the global south is not the result of an integrable problem thwarting our best efforts to prevent and cure disease. We have the means. Rather, as an accomplice to contemporary imperialism, public health messages, it does this through bourgeois empiricist models of disease causation. It is important to have a small discussion on the words that I just highlighted. The first is most global health issues are not continue to be persistent, not because they cannot be cured, but mainly because we don't have the will. That's one. Secondly, because as a global health community, we don't use the right processes, we don't use the right procedures, and the models, what is considered the right methodology, is still kind of dominated by methodologies that come from the global north. And in course of my discussion, one of the questions that we are going to ask ourselves, or one of the core ways forward, is we have to rethink what knowledge is, who defines knowledge, how we value knowledge, and whose knowledge and for whom. If we have a look back towards history, we understand that there was like a very methodological move from tropical medicine to international health to global health. And most of these transitions were actually guided by infectious disease. And most of the infectious diseases that guided these transitions are mostly prevalent in low-income countries. I'm thinking of HIV, I'm thinking of TB, and I'm thinking of NTDs. For instance, if we look at core institutions in the global north, we are thinking of London School of Tropical Medicine and Hygiene, Liverpool School of Tropical Medicine, and all that, we need to ask a fundamental question. Until recently, how many of these schools of global health were found in the global south? Or as we speak, how many recognized and robust institutions of global health, as per se, maybe students graduating from these institutions with masters in global health are found in the global south? Why should an Ethiopian student, for instance, do a master's thesis in London on clinical or epidemiological aspects of malaria in a place where somebody might have spent their entire life without seeing or heard a case of malaria? How many major conferences dealing on global health issues are held in the global south? With the visa appetite reality that everybody knows, what actually justifies a global health conference on TB in Vancouver? I love Vancouver very much, but the burden of TB is not in Vancouver. So these are fundamental questions that mandate the decolonization of global health. We cannot say that something has not been done. We already have success stories when it comes to the decolonization of global health movement. There is increased awareness, and we cannot take that for granted. Equity-focused funding, we know that organizations like the Wellcome Trust and Gates Foundation actually using the localization agenda and funding local organizations. Institutions are adopting frameworks like the Research Fairness Initiative to ensure equitable research practices. Most institutions in the global north are actually rethinking their curricula. When it comes to representation and leadership, a lot is changing in that direction, but we still have core questions as the discussion actually follow. And when you look at the collaborative models, community engagement and co-creation are actually increasingly being prioritized. And most interventions now are co-designed by local communities. But there are still core questions. What are best practices in community engagement? What are best practices in co-creation? And also the focus on community, on strengthening the capacity. It was intentional for me to highlight building and counsel, because most of the time there is capacity in the global south that simply needs to be strengthened, not actually it's not about capacity building, it's actually about capacity strengthening, because the capacity most of the time is there and at times ignored. There is a lot of rhetoric and there are fears that the decolonization of global health movement actually risks becoming a buzzword. Why? We can think of tokenism and symbolism. Without meaningful structural changes, decolonization risks to become performative gestures. And I think of Mauda Pai, who talks of, when you look at international aid, what he actually calls performative charity. There is the elite capture of global health. If we don't take care, most, as we're going to see when it comes to the publications on global health or decolonization of global health, we realize that almost 80% of these publications are published by authors from the global north. We actually lack clear frameworks on how to decolonize global health. We're going to see that the theory that actually guides the decolonization of global health scholarship is sparse, is disorganized, and core persons or core fields that are supposed to be involved in this particular theory, I'm thinking of historians of science and medicine, politicians, are actually absent from the discussion. There is still exclusion of local voices. And if not anchored if decolonization is not actually anchored on authentic community-led processes, the movement risks actually reinforcing existing hierarchies. If we actually fail to address the root causes, it means we are really not doing anything. There is evidence of elite capture of global health or elite capture of the decolonization of global health. If you think of superficial representation, the evidence is many global health organizations have increased diversity in leadership roles, but actually fail to relinquish real decision-making power. The North still continues to control the funding. Cooptation of language, English language is still very dominant, and the terms or the words partnership or collaboration are often used without actually addressing structural imbalances. It's clear when you look at the publication space, there is evidence of unequal research authorship, as I mentioned, with 80% of global health research on Africa authored by non-African researchers, and there is clear marginalization of local knowledge systems. Indigenous and local health practices are frequently sidelined or framed as supplementary to Western models. This is something that is actually key when it comes to the decolonization or the true decolonization of global health. As I mentioned, Krugman has actually described in his very popular paper, I recommend this paper, is published in PLOS Global Health, that the concept of decolonization of global health is being now used by elite global north institutions and organizations to imagine their reformation. Let's look at the role of language within the decolonization of global health movement. And I think this is one of the aspects that has been recognized as important, but very little action has actually been taken to actually address the impact of English language dominance in global health. If you look at the anthropology of language, it's really important to see that language plays a role when it comes to power and representation. Language shapes narratives and this defines whose perspectives are legitimized, access and equity, documentation, funding. Language is an issue. Preservation of indigenous knowledge. Language is actually something that is deeply tied to culture and knowledge systems. You can just imagine that if you are somebody who has learned a second or third language, there are specific things when you hear them in the first or third language, you actually need to translate into a local language before you actually make sense out of it. So you understand the importance of language and the impact of not actually recognizing the centrality of language within the decolonization of global health movement. Framing of problems and solutions. If you don't understand the language, it's difficult for you to properly capture what people are talking about. When we talk about ethics and agency, you cannot properly provide informed consent to actually analyze the scientificity of a particular project if you really don't dissect the language. So one of the things within the decolonization of global health movement that has actually failed to be prioritized and acted upon is the overdominance of English language within the decolonization of global health or within the global health movement, practice, and scholarship. We cannot talk of decolonization of global health without thinking of what is expertise within who is an expert in global health, because if you don't understand the subject, then what are you decolonizing? And there was an interesting paper by Chemako and colleagues last year in PLOS Global Health on actually dealing on who is a global health expert, who qualifies as an expert and who may not, and why is it important? There is neither a universally accepted definition of global health expertise nor credentials to decide who is an expert or not. But we know that expertise in global health is complex, multidimensional, and context dependent. It goes, and this is really important, it goes beyond academic credentials and technical skills, requiring a deep understanding of social, cultural, political, and economic factors influencing health across diverse settings. It's true that we don't actually have consensus on who is a global health expert, but we can know who is not a global health expert. And it's really important to understand and to know who is not a global health expert. If you have knowledge without understanding the context, you are not a global health expert. If your understanding within the field is one dimension, I'm thinking of practitioners with experience confined to a single country or discipline without exposure to other contexts, it's hard to say you are a global health expert. If your knowledge is superficial, for instance, you only engage within short-term on critical global health work without understanding the ethical, social, historical, and cultural dimensions, you can't say you're a global health expert. And savior complex advocates, those who approach global health with a paternalistic mindset, assuming Western superiority or imposing solutions without local input, are not global health experts. Not global health experts if we think of the core dimensions of global health, where we have equity, solidarity, justice, humanity, and ethics. How can we effectively decolonize global health? The first is we need to redistribute power and resources, shifting of decision-making authority and funding. We need to revise our curricular and narratives. This is actually going on already. Update our curricula to actually include diverse perspectives, histories, and contributions from low and middle income countries. And we need to promote equitable partnerships. This is really very, very important because in the general discourse, everybody talks of equitable partnerships. But it's important to understand what an equitable partnership is, how to monitor the partnership to be sure that it's equitable, so that in case the partnership is no longer equitable, you can exit in respect, with a lot of respect. It's, as I mentioned, we cannot effectively decolonize global without addressing the language representation and challenging the structural inequalities within the system. Indigenous knowledge and local knowledge is key because recognizing and validating knowledge system practices and epistemologies of indigenous and marginalized communities, it's really very, very important. And we're going to realize that if you look at the major threats to global health now, the rise of the anti-science movement is a core issue. And why is the rise of the anti-science movement a core issue? It's really important because if we don't do good research, if we do bad science, the anti-science movements are actually going to come into this, because if you allow space, somebody is certainly going to occupy the space. And if trust in science becomes very critical, we are thinking of vaccination and vaccine hesitancy. It's really important to root everything that we do within knowledge systems, with local knowledge systems, indigenous knowledge systems, cultural realities, so that people can trust the science and accept the evidence-based recommendations that are actually proposed by public health professionals. We need to redefine knowledge production processes. Not only redefining knowledge production processes, but redefining what knowledge is, who should value knowledge, and what is considered knowledge, and who actually classifies whether this is knowledge or not. It's important to shift power in research design, data collection, and analysis to local researchers and communities. In my view, I think that when it comes to knowledge in global health, or the way knowledge is conceptualized in the field, is very reductionist. There are specific realities that can actually be spoken, or we can only get from communities. For instance, if you look at what is actually happening with the impact of climate change on health, climate change did not start affecting communities 50 or 60 years ago. Climate change has been affecting communities for decades, and communities have been surviving for decades. Therefore, it's just important, if you are centering or building an agenda on climate health and change, and climate change and health research, you should ask the communities, because these people have been impacted by climate change. They have adapted climate change. They have built resilience to climate change. They know what is important. They know how they are impacted, and they are central in the discussion to tell you what they want, how they want to do it. And most of the time, if you look at what is happening within all the Wellcome Trust and all that, it's true that Wellcome is doing quite some work now when it comes to research prioritization, and WHO as well. But in the past, decolonization of global health, it's important for the communities that are affected to be central from the research prioritization part of things till the implementation and evaluation sides of things. We need to foster actionable frameworks that are actually rooted in local realities. We look at most of the frameworks that are used within the Declaration of Global Health discussion, they are kind of abstract. Move beyond binaries, incorporate community-led participative methods, amplify voices from Global South in research and policy, and promote epistemological plurality by including indigenous knowledge systems and multilingual practices. We come again when it comes to the notion of the dominance of English language within the global health scholarship, research, and practice. Joan Siverna actually gave like very good points on four effective ways to decolonize global health. The first, he says, don't accept the status quo. And it's really very, very important, because accepting the status quo, nobody is actually going to come and decolonize global health for you. And they say, respect is not handed on a platter of gold. We need to change the way we teach, because most of the time you can find a master's in global health student from a global health North institution. When he goes to the global South, he feels that he's an expert. But the problem is not it doesn't arise from the student. At times, it's because the student was not taught. So it's important for us to change the way we teach. Building local power is really important in building local expertise, local capacity strengthening. And find out if you are a colonizer or a decolonizer. It's really important because we cannot decolonize global health without a level of authentic awareness to know whether we have colonizer views or decolonizer views. And he says the victims of injustices must be the primary drivers of change. That's why it's important for colleagues from the global south to be intentional, proactive, and courageous to drive with respect the decolonization of global health movement. David Mackay and colleagues have actually developed, wrote a paper in the Bulletin of World Health Organization on developing an agenda for decolonization of global health. And they started with a quote from Kwame Nkrumah, who says, fundamental to all forms of colonialism is the use of ideas and narrative by colonialists to enable and legitimize colonial practices. And they actually highlight three forms of colonialism when it comes to global health, that there is colonialism also through global health, colonialism within global health, and colonization of global health. And the decolonization of global health must address the relationship between global health actors and contemporary forms of colonialism, in particular the current forms of corporate and financial colonialism that operate through the globalized systems of wealth extraction and profiteering. We cannot ignore the role and the power, for instance, that pharmaceutical companies play within the global health architecture. And ignoring this reality and attempting to decolonize global health is a fiasco. Decolonizing, in my view, then decolonizing global health means dismantling inequitable systems, amplifying marginalized voices, rethinking power, knowledge, language, and partnerships, and embracing continuous reflection to foster justice, inclusion, and equitable collaboration for lasting transformation. I think when it comes to knowledge, epistemic reductionism is a core barrier to meaningful decolonization of global health, and why much of the current global health publishing landscape is restricted in its epistemological diversity, relying heavily on a biomedical lens to examine and report global health, and the exclusion of the social sciences and other disciplines within the decolonization of global health movement is actually an issue. We cannot be studying something that is historical, something that is political, something that is diplomatic, and something that is economic. But when you look at the people that actually dominate the space, you have very few social sciences, you have very few historians of medicine, you have very few political sciences, and very few diplomats that are actually interested or actually involved within the discussion and the thinking when it comes to decolonization of global health. The value of tacit experiential local knowledge, I think I've already mentioned this, and the superiority of particular forms of evidence over others. This is really important, because if somebody has been impacted by climate change for the past 30, 50 years, he's the best person to talk about community resilience in climate health, community resilience when it comes to climate change. And he's the best person to actually tell you how people or human beings are impacted by climate change. Who knows better? That person should be the better expert. Also, from a scholarship side of things, there is actually a lot of superficial theoretical engagement. As I mentioned, everybody is a global health expert. If you look at the core theory when it comes to within the decolonization of global health movement, there are really very few theories, or very few robust theories that actually guide thinking. And as I mentioned, the biomedical model dominance is actually not doing service to the decolonization of global health movement. Global health is often shaped by foreign perspectives. This is still very clear, and the dominant global North funding models still continue to perpetuate imbalances through opaque and biased funding practices. In my view, I think that when it comes to the limitation of decolonization of global health scholarship has actually been emotional or knee-jerk, in my view, because most of the time it's generally reactionary with superficial research practices driven by immediate emotional responses. I don't think we have, as a movement, actually invested clearly, or as we should actually do to actually, when it comes to scholarship from a theoretical side of things, the theory is still very superficial, and we need theory driven by transdisciplinary teams to actually drive this movement to render it meaningful. What are my views when it comes to the future directions of meaningful decolonization of global health? We need a critical mass of true, courageous global health scholars who understand the challenges. Interdisciplinarity and transdisciplinarity. It is very clear that global health, decolonizing global health, is going to require people from various disciplines. But it's not because you bring people with high technical expertise from various disciplines and put them into the room that are going to work or that are going to have results. It's important for us to empirically come up with best practices on how to make people work together. It's important to go beyond the biomedical model. I'm thinking of including the social sciences, bringing linguists. It's clear that the role of language in decolonization of global health is of highest importance. We need to broaden the key actors that are actually working within this particular space. There are key fields that are lacking, seriously lacking within the decolonization of global health discussion. I'm thinking of political science, international relations, diplomacy, and history. And if good science and good policies bring change, then there is nothing. If we are excluding politicians or the politics within decolonization of global or the diplomacy within this particular discussion, it's a farce. And I would like to insist on the diplomatic aspect of things. It's important to be on the table where things actually happen. And if you look at most of the core courses, executive courses in global health diplomacy, they are in Toronto, they're in Geneva, they're in Stockholm, they're in Yale. It's very hard, rare to actually find a global health diplomacy course in the global south. It's really important and a priority for global south practitioners to get involved in global health politics and global health diplomacy. We need to rethink the relevance of knowledge. What is knowledge? How does a theory of knowledge actually, what is a theory of knowledge for global health? This is really important. In my view, there is actually nothing as health policy. What we have is health politics. So it's important for people to get involved in politics. It's important for practitioners, politicians to get involved in the health thing. This goes same to public health and it goes same to diplomacy. We cannot talk of effective decolonization of global health without being intentional in carefully integrating these dimensions in global health policy, global health practice, and global health scholarship. Science communication competencies. Is true that the global health community, if there is one thing that we have failed, we are very poor in science communication. And one of the threats, if you look at the anti-science movement and also the infodemics, misinformation and disinformation, those are the key threats of our times. We need to do better at that. We cannot decolonize global health without thinking about these particular areas. And as I mentioned, we need to get involved, historians of science and medicine, in the particular discussion. And practitioners or people from the global south, we have to end the blame game. We need to take responsibility. It's an obligation to fund research if we believe that research brings change. Raise funding locally and see how we can invest or get the best we can get from local philanthropy. Equitable partnerships. This is really important. Equity is central to global health scholarship. But if we are decolonizing global health, it's important for us to understand the various dimensions of equity, prioritizing fairness, shared decision-making, mutual benefits, challenging the traditional dynamics of power. This is really important, and it shouldn't only be about appreciating equity. It should also be about monitoring equity, because it's important to leave a partnership if it's not equitable. But it's also important from the responsibility side of things for the global south practitioners to actually rethink their partnerships. There is a lot of growing concern that we have lots of growing concerns with inequitable south-south partnerships. And if charity begins at home, it's important for south-south partnerships as well to be equitable. Larson and colleagues they came up with an equity tool that actually provides a practical guide to monitor equity in partnerships. where you have four main dimensions around governance and process, progress and impacts, processes and operations, and power and inclusion. It's important to do research. Research is central within global health. Research is central within the decolonization of global health movement. But I love this particular citation, which comes from the British Academy. Excellent research should encompass not just ideas and outputs of research, but also how the research is done. The methods, the processes that are very key if we actually want to decolonize global health. Is the Ubuntu philosophy relevant to global health? I would say yes. Is it relevant to the decolonization of global health movement? I would say yes. Ubuntu can be encapsulated in the phrase, I am because we are, and it promotes a collective approach in global health practice in which there is active solidarity, mutual respect for knowledge systems, intentionality for mutual learning between the professionals from the global north and global south, centered around diverse populations which it serves. Intellectual humility and inclusive epistemic recognition are key. Expertise in global health transcends degrees and technical skills, requiring contextual understanding. True experts foster inclusivity, while those lacking global context depth or ethical engagement fall short. We need to be intentional to rethink how we train our global health students, most importantly, the global health students from the global south. It's important to be intentional to fight against inferiority complex, to fight against the established saviorism models and it's important for us to insist that they should value co-learning or parallel learning. For us, as I end, it's important we cannot decolonize global health without genuine acceptance to know exactly whether am I in the position of power or not. Global health has to be theory-driven. We need to go shy away from the superficial scholarship that actually characterizes the current global health movement or the current decolonization of global health scholarship. We need to be inclusive in recognition of disciplines, as I mentioned. Social sciences have to become, we need to shy away from the biomedical model. Not enough to advocate for interdisciplinary research, but we need to get best practice on how to make people to work together to solve the complex problems of our time. We need a critical mass of courageous people that are going to stand, because if you think of the choice of where conferences are being organized, you shouldn't attend all conferences. We look at visa appetite, which we should be able to advocate for particular countries to come up with visa diplomatic reciprocity. Allyship is actually key. We must collaborate between actors, global actors in the global north and global south. And as I mentioned, understanding and monitoring partnerships to know exactly whether they are truly equitable so that one can decide to stay or to quit is really important. We must not partner in everything, and we need to partner in dignity. I know I took a lot of time. Thank you very much, and I'll be happy to answer any questions. Thank you.
Thank you, Lucio, for that really comprehensive and thought-provoking presentation. I normally start with a question, but because we only have about 15 minutes of the time, I thought I would just open it up and I'll go last. If anyone else, does anyone have a question they'd like to?
Okay. Hi, Dr. Baines. It's a wonderful presentation. So my question is linking with the reading material of the course, because I'm a PhD student here. It was an article from the Global Health and Research Advocacy Journal from the Chinese authors. And they mentioned about that China actually kind of achieved a decolonization, especially with related to global health. And so I need to kind of go through the details of it, how they achieved it. But they mentioned one of the important principles to achieve the decolonization is equitable economic ownership. So how do you see this is going to happen, or there is any kind of broad ways to achieve this principle for decolonization of global health?
Okay, thank you for that very complex and important question. So maybe I can think of, I can attempt and an answer to that question from three perspectives. The first is, you would not, if you look at the history of China and you look at the amount of funding that China actually allocates, the percentage of their GDP to research, it's really significant. If I compare that with what is happening in most sub-Saharan African countries, where most countries actually provide from their GDPs about 1% of the funding to fund research, it's a complete difference. The Chinese are very intentional. The GDP is really high. And if you look at what they invest in the research architecture or the research infrastructure, it's completely different. From a philosophical or mindset side of things, China believes that research drives development. And most other countries, if I look at most other countries, in theory, they believe that research drives development. Because if you believe that research drives development, you're going to fund research. And most of your development agendas are going to be guided by these people that do the research. That's the case in China, but this is not the case in most other countries. The third dimension of things is, if you look at how you cannot ignore the power of economics. You cannot ignore the role of the size of an economy. China, from an economic side of things, is huge. And if you compare with other countries, if you don't have research, is money, and that's just a fact. Thank you.
Rupsha? Yeah. And then we'll go to online to
Hi, Professor. Thank you so much for that presentation. It's really comprehensive and really unpacked what decolonization means.
speak up, please.
And I was just wondering, just as a PhD student who's interested in co-creation, I was wondering if you could comment on, the trust building that needs to happen in a co-creation process, and the time frame and sort of the pressures of being in a institution that is driven by sort of efficiency, timelines, and sort of a colonial framework.
No, thanks for this very important question. And I think one of the central questions within the global health discussion now is trust and trust theory. And maybe I can refer you to Zacharias. He's a professor in Spain who has done a lot of work on trust theory, most importantly in COVID-19. He actually came out with a framework with 10 dimensions of trust and whatsoever. But if I go back to co-creation, I would think it's a continuum, and to build trust, it actually takes time. And it's important to note that science and trust, or trust in science, is difficult to build, but very difficult to destroy, and at times almost impossible to rebuild. That's why we need to be very careful how we do science. And that's why in my talk, I mentioned the comment from the British Academy. It's not only about the outputs that we have within the scientific enterprise, but the process is how we do the research is really important. For instance, if you do unethical research, that remains within the particular community. That remains in the particular community. It stays on the minds of the people. And the impact is not only on your particular research. Even in the next 10, the fact that you did unethical research is going to be transmitted from generation to generation. So doing unethical research or exploitative research doesn't only affect your research at that particular point in time. It affects a generation of people who are going to be doing the research. That's why we really need to be very careful. And in terms of co-creation, this is really important, not only from the ethics side of things, because at times we talk of co-creation, but we really don't co-create. If you get into a particular community and many look for people that have a lot of power, a lot of influence, or in terms of incentives, you give very huge incentive for people. People are going to sit there not because they want to think, they want to reflect, they want to concrete or authentically contribute. They are going to be there co-creating in theory, mainly because of the incentives. So we have the notion also of ethical or authentic co-creation. And all of these are actually related or have a connection to trust in the long run, which can actually impact how people trust science, or how people will be interested to do research or to participate in research in the long run. Thank you.
Thank you. Great. So let's go on to Emmanuel.
Thank you very much, Lucho. Good to see you. And thanks for the excellent presentation, quite thought-provoking. My question or maybe comment will be, is there any global organization currently working on this very important topic? You mentioned that there seems to be a global consensus. If that is the case, is there any global organization currently working on this? I think we need to have, beyond having a framework, we need to be able to measure progress with implementation, in an objective manner, so we know whether we're making any progress or not. And then we are able to move it objectively from activism to reality. The other key issue, which we probably need to talk more about, is that we need to use a win-win approach. So it's not about handing power to the global south, but we're having a discussion that is beneficial to all concerned. I think we need to highlight that point. There is going to be a win-win situation. I think that will help. Considering the current manner in which global health is funded. And this is key in implementing decolonization of global health. So if you don't use that diplomatic approach, win-win approach, highlighting the benefits to all concerned and how it will move us forward in global health and attaining health outcomes, I think it will still remain in the realm of activism and not reality. Thank you very much.
Thanks so much, Emmanuel, and nice to see you. Yeah, and I think you mentioned, I know, yeah, there are already organizations and universities. I can think of the University of Washington and the University of California, San Francisco. They actually have frameworks already on how to decolonize global health. And I think they have to actually, it's important for us to measure, because what is not measured was not done. And I think there is quite some work that is being done around that particular area, but in a very primitive stages, and it's not been vulgarized enough. The second, I know that at the University of Global Health Equity, we have some fellows that are actually working on the decolonization of global health surgery index. That I know there is quite some work that is actually being done around that. And there are two authors. I'm thinking of Sam Oti working with the International Development Research Center in the research center here based in Nairobi, and also Mahuda Pai that have written recently on allyship in global health. That's why I completely agree with you that it should be something, a win-win. It's not actually that we are actually fighting power. But you ended with a very important point from the diplomatic side of things. And that's why I mentioned that we need to invest when it comes to, or train people when it comes to the skills in global health politics, global health diplomacy. And most of these institutions and these practices, most of the time, are still found in the global north. And I agree with you that global south practitioners should increasingly be trained in these particular disciplines, and we should have training centers or institutions that actually work or train people in global health diplomacy in the global south. Thank you.
Is anyone here? We'll go online. Okay. All right. Yeah, it was Michael first. Okay. All right. Yeah, Michael, please.
Hello. Thanks for your presentation. The decolonization of global health sounds to me as a project that reacts to history. I don't think that can be defined any other way, which presents you a particular challenge, because in this reaction, you also have to keep in mind what your objectives are. And there seems to me a struggle between letting go of the past and imagining the future. So, for example, you haven't said much about the new public health order from the African CDC. And I'm trying to see perhaps if you could make some comments that demonstrate how the extent to which that success has been realized in this context in letting go of the past and trying to imagine a future that is objective of that past. And that last piece, I think, is very important.
No, thank you very much, Michael. And I have a very unique view on this particular subject. In my village, they say, if you don't know where you come from, you will not know where you are going to. That's why I insist on the importance of the historians of medicine to get into the discussion when it comes to the decolonization of global health. We need to understand properly with proper robust methods where we are coming from, because if we don't understand that, I don't think it's not just about forgetting, but it's about understanding where we are coming from, the whys, because there are still lots of things that are still going on, not good practices within global health, which have to be documented. We need historians of science, historians of medicine to help us in this particular discussion. And I completely agree with you. It's not staying in the past, but looking at the near future, and African CDC is doing just that, as you mentioned. And if you can look at, if you know exactly the motto of Africa CDC, which I'm a little kind of versed, they know that what they are saying now is that the new competition is collaboration. And that's why they are actually core and centered when it comes to partnerships. Thank you very much.
Okay, thank you. Mustafa, you would like to go next?
Yes, I'm here. Thank you very much, Dr. Lucio. I'm very happy to see you and to hear you. I'm very happy to learn a lot about your presentation. It's very, very important to me. I'm an anthropologist, medical anthropologist in Quebec City, and I come from Senegal. And I have some comments about your presentation, Dr. Lucio. For me, we must think about faculty of medicine in Africa. You know, it's programmed to put some course on anthropology. You know, it is my comment. And I think in North, they have not skills to understand people who come from outside. You know, when people come from outside to have some problems for health and to go to the doctor, the doctor don't have some key to have a right diagnostic about this, you know, disease, you know. And it is the same when you go at the global south, you know. Doctor and medicine don't put the local knowledge of health, don't have many knowledge about local knowledge of health. You know, it's very important to have some connection of community when you can resolve health community. It is my comment. Thank you very much, Dr. Lucio. Thank you.
No, thanks so much, Mustafa. I'm aware of time, but I can comment on that. I completely agree that, as I mentioned, the biomedical model, when it comes to not only medicine, but global health, is very, very reductionist. It's important to bring in the social sciences within this particular field. And I can recommend you to a paper that I wrote on published in Philosophy of Medicine, and which is actually the role of the humanities in medicine. Because one of the greatest physicians who spoke about this, Edmond Pellegrino, from a theoretical side of things, has actually written a lot on the role of humanities in medicine, and that is central. So I completely agree. Social sciences, and most importantly, anthropology, should remain key within, not within only within the medical discourse, but within the global health, and most importantly, the decolonization of global health discussion. Thank you very much.
If you can share some lecture about your presentation, I keep it. Thank you very much, Dr. Lucio.
Thank you. I will do just that.
Okay. Thank you so much, Lucio, for that great presentation and for the dialogue and discussion with all those presenting questions. So, sorry?
No, I'm just begging to say something, which is
interesting. Go ahead.
No, it's related to what we just witnessed now, which is what Lucio just reflected in his talk about the language of global health.
Yeah.
We've just seen Mustafa struggling to communicate, to express.
Yeah.
of course, the dominant language is English.
Of course, it is the key example.
So it's amazing. Yes. It's just amazing that I was just sitting here and, it just sunk in. But anyway.
Yes, it's true. We try and all come toward English, but it kind of neutralizes everything in a way that it washes out subtleties and people's ability to communicate. But nonetheless, I think we all learned a great deal from your research, a very thought-provoking, and I would say foundational talk to begin both this winter term for our seminar series and sort of the first talk for our winter term for the PhD course. And thank you so much, and we look forward to engaging with you. Hopefully this is just the first conversation we have, and we can continue to dialogue on this topic, to learn from you, and through our program help build on it, some of the frameworks and templates that we can use to address decolonization. So thank you very much for your time.
Thanks so much. Thanks for the invitation.